everybody for joining. A very special event at CSEP. For those who are new, Center for Social and Economic Progress, I've actually been public policy think tank. We work on many policy issues, and health policy is one of our important work programs. And today is a very special discussion on development assistance for health, DAH, which has been, I'm tempted to say, under the scanner, a point for discussion for many years. It's very useful and much needed, let me put it like that, much needed in some countries where it is a significant part of the total health expenditure, but a reasonably small part in other countries such as India. But, quite apart from the financial value of development assistance, there have been many questions around it in terms of what are the benefits? Is it influencing national policy? Is it building capacities? Is it creating dependencies, et cetera, et cetera? And obviously, the responses to these questions will vary across countries depending on what country we are talking about. So our speakers here, and I'm just going to introduce them, have been working on analyzing development assistance for health globally, right? For 2 years, and developed this really robust body of work. So we're very, very grateful, honored, pleased to have them here to share that work, given the importance of this topic. It's a complex world. It's a very swift-moving world, and so even in the context of development assistance, a lot is happening. We know what's happening with USAID. I should say U.S. government. We know what has been the impact of that. So some questions were there traditionally. Some more questions have been added, just given the complexities of the global world today. So our guests are going to answer a lot of these questions. So I'm honored to have Cristian Baeza, who's the executive director of the International Center for Health System Strengthening and the Center for Healthy Development. Cristian has many years of experience with health systems, global health. He's had leadership positions at the World Bank and in his home country, Chile. He has a very long resume, so I'm not going to get into that. Thank you so much, Cristian, for coming here and sharing with us your work. Carolina Velasco heads the research at Instituto de Políticas, Públicas and Salud in Chile. She has been the former presidential senior advisor in Chile and a senior advisor and researcher at Chilean think tanks. Amrita Agarwal, apart from being, I'm sorry, I have to start with this, a visiting scholar at CSEP, led the health system design work at the Gates Foundation, a very, very, very complex piece of work, which was reimagining health systems in India. And before that with consulting firms, and after that also with the private sector. She has her hands again in many pots, so it's hard to define Amrita. So thank you all. Cristian, Carolina and Amrita are part of a large global team of researchers that worked on this report from different countries and different institutions, and the three of them are here today. They will present the findings, and we are really honored and happy to have Girija and Somil, who are going to share their sort of take on the findings presented. Dr. Girija Vaidyanathan has been Chief Secretary, Government of Tamil Nadu, before that the Health Secretary, so comes with years and years of experience. She tried to say today that it's been many years since I engaged with this, but completely untrue, because she's been researching and publishing and is as clued into what's happening in the health space as ever. Somil Nagpal is the lead health specialist at the World Bank, has just transitioned into a different role, is focused on South Asia, previously with East Asia and the Pacific region on the health, nutrition, and population. and of course, very, very familiar with Asia, with India and several countries in Asia. So thank you all. And we look forward to this. The way we will structure this day is maybe, this afternoon is about half an hour of presentations, give or take, and then half an hour of thoughts, input from the discussant, 10, 15 minutes each, and then Q&A from everybody. And Somil has a hard stop at 5:30. I do remember that. So we'll hopefully wrap up a couple of minutes before that. Thank you once again, and over to you, whoever's starting.
Thank you so much. Delighted. I will apologize immediately. It's 6 a.m. for me, so I can blame the time for any incoherence. So forgive me for that. I'm Cristian Baeza, and I had the pleasure to facilitate this work. This is the result of 3 years, actually, of work. Some of us got together once and got enthusiastic and said we've been involved in global health for 20-something years. Some of us involved in approving probably a few billions of dollars of DAH. And we said, what happened? What was the impact of it? Do we know that? And we had this fantasy that it would be an easy, walk in the park. We would, go out, get to look at the literature. We'll get in 6 months probably a bunch of evaluations, and then summarize them, and then do the summary and publish in 6 months. We'll go on. It wasn't the case. As you will see, we actually didn't find what we were looking at, so it was a long journey. So today, I'd like to present the next one, please. The results of our work is based on our report. It's a very extensive report, and you can use this QR to download the report and also to download all the data. So all the data that we are using in this report, including all the publications and all the databases, also including the coding for the AI analysis, all of that is open and is available to you if you like to use it and replicate the work, or even, criticize it constructively. What I'm going to do today is 4 things. One is very briefly refer to the rationale, the objectives, and the research questions and the approach first, very briefly. Then I will go through the key findings, essentially 3 areas. One was a very deep literature review we did. The second, a sort of descriptive analytics of the trends and challenges in the last 30 years for the AH. And then finally, a review of the existing statistical analysis and our own statistical analysis, which was really very substantial. And then we also dare to have our own perspective. Many of us, you can see in the report, we are 14. Many of us are forgotten but never gone, but we had a long career in global health. And so we dare to have a perspective on how we see DAH moving in the next 10, 15 years. This was finalized in January 2025. So you can imagine that even our worst scenarios of risk were nothing as compared to what has happened in the last few months. And then we also provide a few recommendations, specific recommendations, a lot on architecture and next steps. So let me just go directly. So just for definition's sake, we use the OECD, IHME, and also WHO definitions of DAH, Development Assistance for Health. Is basically all the assistance that can be either directly imputed as financial assistance, or it can calculate it if it is in kind as financing. So the benefits of that is that there is abundant information, not extremely robust, but a lot of it, particularly by OECD and IHME. The problem with that is that we are missing all of the assistance that is not translatable into financing terms, which is really important regarding the policy dialogue and the technical dialogue. which for countries where the DAH financially is really small, is probably the core of the issue. And I would say India is one of them. So you'll hear me many times referring to we are missing this part, which is probably the most important part in the non-financial assistance area. ¿Me das la siguiente? The next one.
I'm following that.
Perfect. That's great. So DAH, if you look at, it has invested in the last 30 years around 880 billion. If you include 2025, and you will see that we stopped at 2019 because we thought that interpreting the data on DAH in the COVID area was extremely difficult and will distort the analysis, but we still look at it, but just didn't include it in the analysis. So it's around $900 billion in the last 30 years, and it's around $1.2 trillion in the last until 2025. The majority of that was spent after 2005, more than 80% of it, and around 50% now of all that has been allocated, conceptually allocated, not necessarily cash flow allocated, to countries, half of it. The other half, more or less, is administrative expenses and a category that's called unallocated, which has been a puzzle for everybody. We talked to everybody about what unallocated means. It doesn't mean that anybody took that money in a bag. We don't think so, but it's very difficult to identify ways geographically allocated. And you see in this graph both the allocation for DAH as such and in terms of the categories, and also in the dash, you see the COVID part. We did not include COVID. You will see that we try, but it is a huge distortion at the moment, and now is a huge forgotten issue, which is really shocking. After only 2 years now, almost nobody remembers that we had a big shock on that. So the core objective basically is to answer the question of, so what? So we spent $900 billion in the last 30 years. What happened to it? What is the impact? Did DAH change the needle in any of the dimensions that we imagined when we made the promises, when we got them the money? And based on the evidence, we wanted to conclude with the spirit of being constructive and actually looking at the next 10, 20 years of DAH and how we can do better. So the questions we asked were, what are the trends? What happened to DAH in the last 30 years? Did the DAH organizations deliver on the promises we made when we got the funding and we were the agents of the people in management of those funds in the last 30 years? In delivering what we promised, which often wasn't impact, it was processes and outputs or even inputs. Did we move the needle on health status, financial protection, satisfaction of the people, or even development for countries? Did we also, what is the projection in terms of what we think is going to happen in the next 2 decades? And as you'll see, our recommendations. So we ran 6 main streams, and I will talk about a few of them, work streams. So first of all is a description of the DAH trends. The second is a very deep literature review. Some of us are old now, but some of our young core, colleagues are versed in AI, so they run this literature review with really new techniques. And if you look at the report, you will get all the coding and all the information to be able to replicate it, which it didn't exist when I'm a pre-iPhone generation researcher. So we also did a very in-depth statistical analysis. Both we reviewed existing literature on the statistical analysis, and when we ran our own, my colleague Carolina Velasco will refer to some aspects of that. And then we also look at the outlook, and my colleague Amrita will look at that briefly. Next one, please. Just before I go through the work streams and the results, we are obsessed about how big this is. But when you put this in context, and this graph shows the total expenditures in health in the big bars on the left of the graph in the last, how many years? 20 years. And the world is spending around $10 trillion US, 50% of that in the United States, 85% of that in the rich countries. And that little blimp on the right is what is DAH cumulative. So very, very small proportion. So it is big to talk about $1.3 billion, but as compared to what we spend in the world, is really small. And so we need to have that in perspective. Second is super important for countries like India, also as a proportion of total expenditures. So what you see here is in low-income countries and low-middle-income countries, what proportion of the total expenditures of those countries in the last, since 1995 until 2019, is DAH. For low-income countries, is around 30%. For low-middle-income countries like India, is really interesting, important, but really, really small, is marginal, which is a really important call in the issue of how you use this collaboration that we call DAH. If you think that it will make a difference financially, we are lost. So how do we make a difference with that little money proportionate to the country? I'm not going to bother you with that. Okay, so the first finding, I'm now going to enter into the back. Yes. So I'll do the trends of the AH, then the literature review, which is obsessive to the limit, and then the statistical analysis. Let me begin, next one, please, with the analysis. So one of the concerns we had and motivated this study is that we believe, and the data shows that the DAH is at the crossroads. We had a huge, huge increase in DAH financing from 2003 to 2013 at a CAGR of 10% per year, which is, there is no other sector that has grown in development assistance like that. Lots of my colleagues at the World Bank were not health, were envious of that. But then since 2013, this crossroads is not recent. It's been, dragging for some time now. We saw a stagnation of the growth. So still, significant amounts, but, a beginning of the hesitance of continuing the growth. And then since, I would say 2019, if you take COVID out of the equation, you will see a reduction with a super sharp reduction beginning a little bit before 2025, mostly because of geopolitical shifts in priorities, some of the wars that we are seeing in the world, and donors began, and a huge tsunami in the 2025. There is a reduction of around 50%, and this is still lagging in 2025. Our projection for 2026 is this is going to be even deeper, probably around 27 to 25 billion. So that is a 50% reduction, suddenly, which is really very, very significant. Okay, next one, please. Thank you. Now, the growth we saw there, it wasn't driven by all the healthcare. What we see here is the four big drivers of DAH. And basically, it was driven mainly by the HIV/AIDS push, very significant, which you see in the extreme left, with a very significant CAGR increase, and to an extent by MMCH, by maternal and child health, which began much earlier than HIV/AIDS, but more or less concurrent, and to a lesser extent, tuberculosis and malaria, and almost nothing on non-communicable diseases, although non-communicable diseases everywhere, no matter where, is the one that is killing us today. Next one, please. So the second finding is, this wasn't an homogeneous growth. It was a few priority diseases driven by us, donors, unfortunately or fortunately. And that resulted in what we call an imbalance in the allocation. On the left, you see the share of preventable DALYs, disability-adjusted life years, And you can see, for example, I'm not going to go through all of them, but for in 2019, for middle-income countries, which, by the way, get the lion's share of the AH these days, around 45% of all preventable DALYs, which are more or less 50% of the NCDs, is driven by NCDs, but we got 2% of the allocation of the AH. So there is a major issue here. There is a huge elephant in the room, but it looks like a little mice for the AH, and we have a challenge. And we can talk about that in the next discussion. So that was one of our biggest concerns. And finally, yes. And finally, the other surprise to us was that, when you spend $900 billion, we thought, okay, fine, most of it goes to the country, and, it's spent at the country level. First finding is like around 50% or 47% goes to administrative expenses and unallocated, which we still struggle to know what it is. We believe it's simply a definition issue in the AH databases because it's driven by the UN agencies. So the UN agencies drive like 30% of the AH in non-allocated to countries. Now, where? Next chapter, next chapter of this work. The second is the other 50% is allocated to countries, but when you look at the cash flows, around 25% of the real allocation actually reaches the country. So one quarter. The other quarter is allocated to countries conceptually, but it is spent outside the countries on behalf of those countries. You buy the vaccines, you buy the consultants, and you send them there. So those are the trends, and this is a scene. You'll see 50 pages on this, but I'm just summarizing. Yes.
Colors. Country means donor or recipient?
Country means country recipient. It's a recipient country. Yes.
Is the recipient.
Correct.
45%.
That's correct, sir. Yes, exactly. And the red part is the administrative expenses. Yeah, perfect. Excellent. Okay. So this is a really high level trends. Now let me go to the second part, which is the literature review. So we expected to find, if you spend $900 billion, most of us have been in boards of private sector. If a CEO tells you that they spend $900 billion, you ask, what is the impact? And you have a plethora of data, otherwise things happen, So we thought we would find a lot. We did a very deep research. We look at all the literature for all the organizations driving the AH in the world that at least at any year between 2000 and 2019, they allocated $500 million. So at any of that, we selected them. So these are 16 categories of donors or entities, which in practice, if you include the clusters, is probably like 25, 27 of them. So we analyzed all of them in every aspect you can imagine. And we also selected all countries that were classified as low-income countries in 2000, regardless of what happened to them. And we look at all the literature that referred to either the organizations or the countries from 2000, well, actually from 1984 until 2019. We found, yes. Well, next one, please. That's it. So we found 25,000 publications, and through AI, otherwise impossible, we were able to take them down, making sure they were robust evaluations, and they had internal validity. They were not simply advocacy pieces or other information. And we came down to around 3,700 papers which analyzed. A couple of findings. The first one, which was a surprise, is that most of the evaluations that exist on the AH are what we call the micro evaluations. So they mean They evaluate either a program in a country, so introduction of HPV vaccine in El Salvador. I'm from Latin America. El Salvador from 2010 to 2015 in the provinces of the north, and so 92% of all papers do that kind of evaluation. They do not do an aggregate evaluation. Second, around very few of these evaluations actually look at non-participants. Means you put an impact on a population, you evaluate the impact on that population. The issue is that when you do that, which is a very frequent problem when evaluations in our sector, you are missing the spillovers, the externalities. And so that is a big problem, and the affected people hopefully will be better, but the people who are not targeted might be worse by your intervention. And in this size of interventions, this is not minor. If you put $1 billion in a country that has a per capita income of $500, the effects you can have in multiple systems, labor markets, and on could be gigantic. So you need to do that. We found very few evaluations that would do the aggregate of all the DAH in a country or all DAH in a disease, and even less evaluations on all DAH on all the portfolio of an organization. Very few of them, which was an issue that really pushed us to do a statistical evaluation of these portfolios in more depth. Then, as many of us have been consultants, we came to the question of, go ahead, forward, that's it. We came to the question of independence. So we said, does independence of the evaluation have any impact on the results? Because we wanted to know what results we will show you. And to our surprise, yes, huge. So we classify the evaluators as internal evaluators. So when I look at the mirror, I find myself really awesome, but an external might not. So internal evaluations, external commission, meaning you contract a consultant, but you manage the consultant directly. You are the counterpart. Internal independent, so there are a number of institutions that have independent evaluators that depends on their board, not the staff, and then completely external. And what happened is that there are big differences, not surprising really, if you've done this kind of work in the past. And so we decided of the 3,400 and something to separate the non-independent. So we took out the internal and the external commission, and we concentrated in the independent, which were like around half of the portfolio, like 2,000 of them. And this is what we found. So did we deliver what we promised, which, by the way, in 70% of the cases were inputs or were processes, were not impact indicators. So around 50% of all of the projects that were evaluated actually achieved either full completion of the promise or significant, and 50% did not. When you lift the constraint of not having the non-independent, when you add the non-independent evaluation, this goes up to 61. Still good. Well, you judge what it is. Surprisingly, the independence does not have any difference on the of the evaluation on countries. So if you look at the portfolio from the agency, independence makes a huge difference. When you look at the portfolio of countries evaluations, no problem. So we are equally harsh with countries, although we are not equally harsh with agencies. That's what I mean. We mean by that. So let me just move to the third dimension of the evaluation. So basically, is a statistical analysis. What we did here is, instead of taking a sample of countries, we took everything, all 137 countries that received any amount of DAH since 2000, so 2000 to 2019. And we took all the data of all the of DAH, regardless of purpose and why is important to do the statistical analysis is because as very few actually assess the impact on non-participants, we really need to have an idea of how the overall impact of the DAH on the populations really behave. So that's why we did the analysis. And let me just, so Carolina, if you briefer than me, can explain. Yes, please go ahead. Go ahead.
Okay, so thank you for the invitation. Regarding this statistical analysis, first we review and we found only 9 studies that analyzes, results for overall impact of DAH. And the results, as you can see, are mixed. Some of them find significant and positive impact, others non-significant results of DAH on some health result, and other ones significant but negative, at least one of them. So it was confusing. The reasons are the different data sets, different methods, different inputs, different countries, different data. So it was not possible for us to reach a conclusion. So then we took what Cristian was mentioning, all the countries that received some DAH between 1990s and 2019. And we took what we thought it was a good specification for, running an analysis, a regression analysis. And we obtained very similar results to what was, we call it like a seminar paper, which was the Mishra and Newhouse paper in the 2000s. I don't remember exactly the name. 9. So we reaffirm that there is overall a positive impact, but little, let's say small, positive impact on infant mortality. So we were able to, reaffirm that that discovered. But when we turn to another health results, health measures, the results were different. That is, when we analyze the impact of the aggregated DAH on some diseases, we found different results than previous literature, and also among different techniques and methodologies. And when we moved to evaluate disease-specific DAH to disease-specific health results, then the results were more confusing. So we encourage at the end more studies to be done. 9 is too few, and with all data. And so now if you read the report, you will find that there is an open field for studying this impact on the different diseases. And so that is more or less what we could get.
Great.
Thank you.
Thank you. And as Carolina mentioned, the existing studies, most of them were before 2010. Most of them were with data before 2005. So if you consider that 80% of the age was spent after 2005, there were no studies. Now, I have to tell you again, I work in many boards. If somebody spends $900 billion and you don't have any evaluation, it's a bit concerning, particularly when you spend so much money. So we decided then to do what Carolina just explained. Give me the next one, please. So we also, what we just did here is a scene also. There are like 50 pages of deep technical descriptions of the methodology, so you are invited to look at it in detail. There will be a quiz at the end of it. And so we also did an outlook and tried to understand what we believe is going to happen with DAH. As we said before, this was finalized in January. We did not imagine even in our worst scenario what would happen with the US, which is, by the way, 45% of all the AH in the world. It has been, the United States has been the driver of the AH globally. Amrita, would you like to tell us?
I think this is a story now very well discussed in the health community.
Yeah.
But in the context of our paper, I will recap our thinking during the process of the formation of the paper. And the paper finished before everything unfolded. So just keep that in mind. The future is not likely to be the same as past. We all know it, but inside our minds, shifting gears on the systems is not easy. And as we thought about DAH, we tried to understand what will be the likely impact on supply of DAH in future and what will be the likely impact on demand of DAH in the future. And hence, what do we think about strategies and implications going forward? On the supply of DAH, when we made the paper, we didn't include anything post 2020 in our original paper. But as Cristian has shown, things have dramatically changed in the last 2-3 years. And when we look at what's likely to help increase the DH spending on health versus decrease it, we know philanthropies are under stress, and philanthropic organizations and multilaterals and bilaterals are under stress. And unlikely, the US system may change in the short term, and which is a very large funder for the global philanthropy. And we know in Europe as well, there are many countries which are revisiting their priorities towards DAH. So one is the overall funding towards development assistance globally across all sectors. And within that, definitely, there are other priorities like immigration, poverty, other things. So unlikely that we will see dramatic changes in trends. So we saw since 1995, there's an upward trajectory for health. I think those days are gone. So I think that's a new rebaselining we need to think about. On the demand, which is very different, the need is there. So I'm talking about the underlying need for LICs and LMICs. Disease burden continues to be very high. There's pandemics. We didn't solve COVID health systems for pandemics. There's climate change. And the other thing, important thing, which could reduce the dependence of LICs, especially, 30% of the LIC's health expenditure comes from DAH, is really how the macro fiscal stability and growth is going to happen. How self-sufficient are they going to become? And then how much of that allocation they can do towards health. And we know that most of them are under huge fiscal pressures and debt is rampant. We don't know if they will get debt relief from higher incomes countries or multilaterals. So the short-term picture is not good. So the need is going to persist in the short term. And the long-term picture on whether the demand for DAH can come down depends on a larger set of factors for LICs for sure. And actually, even for LMICs, LMICs have also not solved their health system requirements, though the share of DAH is much smaller there. Now, so where are we now? In the uncertain world there is going to continue to be uncertainty, and we need to think about the value for money for DAH even more. So how can we get a bigger bang for the buck? And that needs a lot of understanding of what has created the value for money in the past, which we don't have enough data for, because right now the data is not conclusive that there's been enough value for money. A lot of money has been spent. There's been some value. We're not saying no, but we need to be really strategic for LICs, but even for LMICs.
Thank you so much. And it's not only the US. So if you look at every single large European donor, all of them have cut DAH significantly. And it doesn't look like, given what's happening in their budgets fiscally, also in geopolitical issues, we are going to be in this scenario at least for the next 5-7 years. So let me finish with some recommendations. Please do look at the report. It's much more granular. We just give you a really fast overview. So there are a few recommendations. The first one is we believe that there is an urgent need to rebalance the from priority disease focus, which has been driving the whole thing, to avoiding, to reducing avoidable mortality and morbidity, increasing for sure the preventable NCDs. There's a lot of debate about this. All the donors have having their own internal battles about this. Nobody's exempted. We happen to be in one quarter, which we believe we are not saying eliminate the other thing, but the imbalance is just gigantic. 2% for 45% of the preventable burden of disease is difficult to sustain. So second, we need to really increase the focus on outcomes, not only on processes and inputs. Most of the promises we've done have been on processes and inputs. We are not saying that only outcomes need to be considered, but a little bit more on actually whether the needle or not is just central to the discussion. That is the promise. Third, we believe it's time for the creation of an independent function that actually runs periodically. We are a bunch of forgotten but never gone, except the new generations. And the fact that we are the only study of this magnitude done in the last 25 years with very little resources, it doesn't speak well of our sector. You spend $1 trillion and we don't. So we are suggesting that there is a reason why that didn't happen. It's not that we forgot, it's that we didn't want to know. And the only way to wanting to know is to have an independent entity that actually pushes this. Why is this important? First, because we believe that we need to know. You cannot know where you need to go if you don't know where you are. But second, there is a humongous gap between recipient countries and those of us who run or have run the donors in terms of the strategic information. Countries, when they face the discussion with donors and the agencies, I had an army, of brilliant people like Somil at the bank, and countries don't have it. So how do you bridge that gap so the countries can make us accountable is really crucial. And the same, believe it or not, is with donors. We had meetings with ministers of finance who really didn't know what we were financing in terms of impact. We said, do you know what the impact is of your whatever $1 trillion that they didn't? So we are proposing that its function is created. We also said we are not interested in actually running this. We are all retired. Somebody else needs to, so we are not creating a business for ourselves. Somebody needs to do that. So if any of you would like to that, we're happy to help you. We also believe that it's really important to scale up a concerted effort for better data. The data is really bad. For those of you, we have really good epidemiologists here. I personally didn't know that most of the data we use to do impact evaluation is model data. So when you do model data, there's no way you can have contrafactuals. We don't know what's really happening, with or without the AH. And model data has improved, but it's not spectacular. We believe that it's crucial to focus on mitigating the effects of these cuts of the AH. We are super concerned that countries are going to need to reallocate from not only from other parts of the sectors to fill the gap of the money they lost, but likely from other sectors. So the impact for countries that are highly dependent will be not only on people who die, but also on future generations' investments in human capital, because education will be beaten, ports will be eaten, highways will be. So there is a huge, and we have had conversation with the IMF and the World Bank colleagues to mount an effort to help countries to make right decisions on the reallocation. And finally, and why not? We are small and nobody, but we made a call to the United Nations to convene a panel to have a conversation about the future of the AH, which really needs big changes. So with that, let me just finish here. Thank you so much for inviting us. We gave you a 3-year summary in 45 minutes, which is very long, so sorry for that. Thank you for the invitation.
Thank you so much, Cristian, Carolina, and Amrita. It's such a rich piece of work. And actually, I did look at the report, and there's so much of interesting, fascinating granularity, which you weren't able to present here, I'd encourage everybody to actually look at the report. It's actually mind-boggling that there aren't evaluations for $900 billion expenditure. But it's even more mind-boggling, and I'm looking at Somil, that organizations like my previous employer and the World Bank, these are all actually very focused on looking at impact. So in that scenario, it is interesting that these don't exist. And the third reason why it's mind-boggling, is that when aid is given, a lot of, now I'm not looking at Somil and I'm not looking at previous employer, that a lot of grants are given demanding accountability, right? So there is accountability for the grants that are given, which are of course micro, but there doesn't seem to be accountability at a larger level. But anyway, that said, I'm also wondering what this means. This development aid for countries where you said this 30% of the total health expenditure. Other countries like India, it's really tiny, maybe 1%, et cetera, et cetera. I think it's very important to understand what is that 1% doing? Because for a country like India, one could argue, and it has been said before, does it really matter? But perhaps it does, because it's not that money, it's possibly doing something very valuable that cannot be done internally within a country. But unless those evaluations happen, it's possibly hard to articulate that. And my last point, which I thought of as you were speaking, that there is an imbalance between the need and where DAH is targeted, is what is happening with the governance of DAH? Again, which are the voices in the governance of DH who are prioritizing where this is targeted? But anyhow, with that, Girija and then Somil, about 10 minutes each. Is it on? I think it's not.
Okay, it's my voice normally carries in the size of room. It's a pleasure to come to CSEP, and I've braved almost cyclone in Chennai to be here, and it's worth it. It was really actually one good thing is that, as I rightly was saying before, it's been 6 years since I worked inside government. I retired in 2019, the same year that your work took, and then I moved to what I call a semi-academic state of retired life, which I'm enjoying a lot, but definitely not inside government. So every time I come for a CSEP conference, I find I read and I learn. And this report was something that, as you said, I think the right word is mind-boggling, because we haven't thought about it in this way. Those of us who have thought or received or been part of aided projects, which we all have been. I'm a retired civil servant, by the way. So through that process, we would have been parts of projects, but we've never thought of it in terms of how is your question to why people like the World Bank or even USAID, they have been evaluating. But that's the point they made, that they're largely micro studies done for that project, mostly done by someone with a vested interest in patting each other's backs. And I was part of the backslapping. No doubt at all. You don't want to say nothing worked. That's where you'll see there that there's a lot of the orange and the blue line. If you could see, partly worked, almost worked, something happened. So the rigorous kind of evaluation which you want to see would not have happened. That's why, but it is mind-boggling to see that placed in front of us by a group which had no other interest except to tell us that this was. So for me, as I said, I did go through the report. I won't promise to have read all 200 and odd pages, but I took notes. And I find this exercise helps in one, thinking about what you have written, because as I read what you've written, and I actually endorsed a lot of it. So it was very tempting not to read more of it, because when you agree with something, you feel, oh, they're saying exactly what I think. But every little, I found this presentation was equally helpful because 45 minutes is not a long period of time. And if this summarized for me again what we said. So on that note, and I'll tell you, as I said, not in, I was in the state government, which is again different. I've not worked in government of India. And most decisions regarding DH actually happen at the central government level. There should be a separate conference just to discuss in a country like India, which receives less than 1% DH, what are the, here we talked about the imbalances that occur between donor agencies and donor countries, between state and center. And I'm sure somebody who comes from Brazil or some of the other Latin American countries which have this federal structure, we've understood DAH through many lenses. And so I have not seen it from the point where the negotiations take place. I have been on the other side implementing or being part of projects. And the point that was made by Cristian from the beginning is so important, that for a country, for a state like mine, which was not in India, one of the more developed states, definitely an LMIC border from the time I entered service in 1981. My first large posting was in the World Bank Integrated Nutrition Project. So I have somehow managed to bounce across many such projects. So what was important was not the money, but the project was used by my then superiors to get many things for the health sector. Meaning I don't know whether it happens as a matter of, like, we had all our village health nurses were placed on the ground as part of this project. The money was paid by the state government at that point, but it was part of the design of the then World Bank project that if you wanted to do this, you also have to build the health sector. And so everything was expedited and packaged. And this we learned from those that went before us, that we used always the possibility of getting funding from an agency to do other things. So it was like a back-to-back, like little children who get candy for doing something. You would go to your finance department with your project and say, hey, this agency is ready, the World Bank will consider a project for us if we do all this. So you put in X, they will give us, maybe it'll only be 1/10 of X, but that 1/10 of X will. So this has been one of the design elements of DAH. As you said, it's very difficult to measure and study what happened in those places. But there was one, I have to explain one small project. It was a Danida project. And you all know that Danida is tiny by definition, but it made such an impact on the Tamil Nadu health sector. When I entered the health sector, people used to be talking about Danida project. If I now look at the numbers, it is tiny. But for the first time, we did community working together to build health centers. That idea would never have been possible with our own government money because there's too much structure in what we do. Similarly, the first time we put in place a OMR sheet this is in 1981, so 40 odd years ago, for the first time, computer read sheets for data on the PHCs. So the person at the field just had to enter, blacken the dots like an exam paper and put it into the computer. And the first time we did this, all these, I'm just building on your point that the things that came about were not things which you can measure. What did these do to improve the health system in Tamil Nadu? This very, 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 not only the point that people tend to measure micro, but it's very difficult to measure the impact of innovation or the impact of change or even of reform, which is it's very subtle. So I just wanted to mention that. I further went on, as I said, I was working in the forest departments, not in health, and we worked with JICA. And so every time I have worked in a funded project, I find that we used it to get things that were unpleasant, which were sweetened by the idea of this is to the staff, this is to, in doing tightening of certain regulations. So one is to the government and the finance department above you. The other is to the people who work with you. Both sides, the small amounts of money have been used to create change. And I think this is something which I don't know how we will measure, but I think we need to design it when we do whatever we do. Another important one, I'm sharing this within my 5 minutes because I think as a practitioner, the many things you have to see is there was a UNICEF project the HIV/AIDS was mentioned again and again. We all were there in that HIV/AIDS era. So this was to create a school-based system for training students to be peer group advisors, and it actually made a major impact. And if you see again, the amount of money spent was tiny. We have retained it. We used it during COVID. We are using it now for NCD. So how do you measure impact of something that got designed with perhaps a budget of 10 lakh Indian rupees? So I'm just keeping that. Coming back to whatever you said, this on disease-based. I think I read the recent Global Health Assembly also. They discussed about fragmentation in DH, and I think you have mentioned it in your report also. These agencies have been created for diseases. They've been created for vaccines. You can't wish them away. They have talked consciously about all of them coming together. But it is a question, who goes, who stays? And those diseases are important. But I think it's a very, very important point that health system reform, which is also mentioned in the report, and focus on NCDs, which are going to be in times to come increasingly the largest contributors to mortality and morbidity. How do you bring them into the agenda if your DAH pie is shrinking? And if people already think that they have to spend it for X and Y, I mean, I think our TB program, for instance, again, a World Bank funded program, another learning lesson for me in terms of the people at Delhi. These are all life lessons for me. The way we changed the way we looked at TB. It came through a World Bank project. Yeah, I'm not saying the World Bank project did it, but after that we looked at TB differently. So I think this, how do we not do away with the focus on certain diseases, but at the same time bring them together and build. And all this, if we had X more money to add, it would not be difficult. We would retain them and add more. Now we are in an era of shrinking. So it seems again and again that this money has to be reallocated more wisely, and for India, countries like India will receive less, but we have to keep looking. So on unallocated flows, again, an eye-opening revelation. I don't even know what it means. It sounds beautifully governmental. I'm sure our budget documents also have some names like that. But I'm going to think more about it. Maybe it will come to me at some point in one of my insomniac nights. This other point I wanted to bring out, which has been discussed again in the report, but I think it's now that I work in the NGO sector largely, after having crossed the tables to a semi-academic state, the only other work I do is with NGOs. These non-government flows are going to get crashed even more. And I know a lot of NGOs. I work with a lot of NGOs, and Maulik also knows we are working with people who work with women's health issues, specific issues. They're going to get hit on all fronts, because when you tighten at some point, the weakest links are going to go. And it's also, I think you mentioned about donor-donee priorities. It's also that when the donor countries are going to put conditions like reproductive abortion rights cannot be discussed, a lot of the work done country to country is one issue. And this, I took most of these notes out of your book only, but I just want to reinforce that I thought they were very important, of the countries, then at least the LMICs, retaining some way to fund or keep alive the work being done by good NGOs, because we have largely depended on some form of external funding. I found the literature review issue also quite interesting, and the fact that you could find only 9 studies finally, I think all this was, it shows that nobody's doing it. And as you said, unless you go with your recommendation of setting up somebody to do only this and do it in a proper scientific manner, I think the future is going to look as bleak. I don't think anyone is going to have anything. I liked all the points about the evaluations. They are very difficult to do. And I think there'll have to be not only a small group, but a whole lot of academics looking at how do you evaluate especially where there are country-wide interventions. Who is your control group? How do you take out the spillover effects? How do you take over trends, the secular trends? It's going to be nobody has attempted it, according to me, very scientifically. Even between states, we haven't done it. So it's something, but as far as I said, the outlook, we are not expecting, Amrita put it very clearly, we're not expecting the demand to come down. They're expecting the supply to squeeze. All the recommendations in my book, everything makes sense. That's why I said there was nothing left for me to say. Rebalancing, this focusing on outcomes is very much there in every project that I've signed or looked at. It's there, but an outcome will always be further down the line. As he said, it will be largely processes or it'll be intermediate things, and it's easier to look at in those. Now there is a lot of performance based. I think the World Bank is pushing towards a performance based lending. That is something that's helping, but people are gaming every system. I mean, you find things, I'm being very frank because it's a small group and I think you'll agree with me. If you find there is some like the substituting state government money for central government money when the central government gives funds, substituting central government money for World Bank money, when that is just making sure you're not adding but you're substituting, again mentioned in the report, is happening willy-nilly. I mean, because your finance departments are playing this game at all times. And I was, out of my 40 years, I spent 16 years in health and 14 years in finance, very close balance. So I know exactly how they think. The point is, how do we write these so that we are true to ourselves? And I think this setting up of a group to think of only these things, as your report has started us thinking, and therefore then to use the limited amount of money better, I think is what I want. As I said, a pleasure as usual. I really enjoyed reading the report, and I would love to do whatever additional work as in terms of collecting some data and seeing what we can do with it in a state like ours, which has a lot of potential. Thank you.
Thank you.
Very nice. Wow.
Yeah.
Thank you very much once again, Sandhya. Let me echo Girija ji in the same way. Pleasure to be here. Pleasure to be with Cristian after many, many years.
Yes, sir.
I last hosted Cristian when I was in the Delhi office of the World Bank 14 years back, I believe. So it's great to see him in Delhi again after 14 years, and of course to take note of this excellent piece of work. Thank you again to the entire team. Let me start by maybe talking a little bit on the question that you raised, right? On the 900 billion. Let's start with the elephant in the room. So, unfortunately, the challenge with the 900 billion is that it's too fragmented compared to the board analogy, right? I would love that there was a board responsible for DAH that could take stock, because then this would not have happened. Our challenge primarily arises that there is no board. There is no way that we have been able to defragment development assistance for health. And that to me is one of the biggest challenges. There is so much of lack of sharing of information or even coordination that probably it is just difficult to fathom who's doing what. In many countries, you have to do elaborate exercises to just understand what the key players are doing. And this is not going to be able to capture the fathom of those players and all the line items that they finance. So it's not easy. That's probably the first challenge that we face in making sense of what's happening. The second challenge is that we may be able to do much better on the micro evaluations, and that's because the timeline for most of the development assistance for health is a projectized period. 3 years in the case of maybe your former employer, but maybe 5 years in the case of the World Bank. But that's the horizon. At the most, you will see low-level outcomes in that period at the end of the period. So your monitoring tool is usually inputs, processes, and some outputs. That's what you have available in that feasible time period when you're trying to monitor. So to be able to see the outcomes, you need a very different M&D instrument and system that often, again, is not available for the space as a whole. Institutionally, there may be mechanisms available to do so, right? There's an external evaluation body at the World Bank. There's an external evaluation body at the Global Fund. There are external evaluation bodies across many institutions who have a very, very independent mandate. I think when Cristian and the team used some of those analogies on where was internal independent organizations, I believe the IEG of the World Bank, the TERG of the Global Fund, and many others of that kind may have been factored in, which do once in a while these mega reports that also look at the outcomes over the years. The challenge is that's one study in a 15,000, and may even get lost in somewhere in the AI to get that kind of detail. But as Cristian knows, there are these periodic IEG sectoral reports that guide us on what has been the impact of our lending and to change direction. And we are not the only organization that does anything like that. So I think we need to also look maybe at I should say, a synopsis of those sources of information versus what's available across in literature, published literature, and where can that also be improved? Because that's a very feasible channel to get more intelligence on this space. So, just sharing that aspect as well. So, again. Something that came up, and I think that's a very important part. I think the only board for DAH will be the countries themselves. If you look at who governs the World Bank, who governs ADB, who governs Gavi or Global Fund, ultimately it boils down to countries. Our entire board are countries, and fair representation of low and low middle income countries now, which is our board, where we have executive directors who represent each constituency. So I think we need to also find ways in which we channelize such thinking as countries to be able to become that board of how the DH coordinates. And there was, I should say, for a long time, at least among the multilateral development banks, because the same countries were on the board everywhere, they're saying, why don't you align better? And there's now been much more efforts to harmonize, find similar rule sets, stay much better coordinated, do more partnerships, and reduce the burden on countries for maybe like something that can be supported by multiple banks together rather than each doing it with its own rules. And all of those structures have now been found. So things are improving on that front. But to me, that semblance of a board will need to find more voice with the countries who are actually owning all of these entities, because this data and this information needs to be presented to that group that sits on the board of those or those organizations. So to me, that's kind of one important facet. The other very important point that you raise is, what is that 1% doing? Yep. Very, very important question. It's minuscule, but it's not a lot of money that's needed to create change capacity. I'll talk about a few C's here, but I think that I will just give some examples. I've been on both sides. I've been on the government side for a fairly long time of my life. I've now 16 years on the bank side of things. But I think one reason why a government officer like ma'am takes this pain of working with an MDB is because of the fact that it's a guarantee to make that system work. Better than what would have been possible by her forces alone. So it's an added force that's available to get results. My minister in Indonesia, I'm just coming from a 6-year stint, decided to create a historical $4 billion project to finance equipment in the health sector all across the country. Nothing like that has happened in the health sector before. And he wanted us to micromanage it, because he wanted to get the details worked out in a way that all the problems that have been there with public procurement in the past are kind of addressed. And there was a solution that we, ADB, AIIB, Islamic Development Bank, came together. The World Bank led the whole operation, but we were 4 banks working together and found a solution that was appropriate to their context. And that's not a unique challenge that Indonesia had, that if you buy equipment, it just remains dysfunctional. You may take it with a 5-year warranty, but the company will send a spare part from its headquarters, wherever it may be in another continent, to Indonesia by ship. It will take 6 months to come, and the equipment is getting obsolete and being not being put to good use. So how do you turn the whole system around its head? Is changed with the scale and with that innovation. We've done something which now makes the companies accountable for operations and maintenance for a extended period, including all proprietary consumables already factored in the price. And there's a penalty if the equipment is down for the 6th day, and there's a 95% uptime requirement. So people did it. Companies are also very happy because it gave them a scale and a direct ability to work with the government without many of the middle layers. To cut it short, we need to find solutions that work for a government, and it's not about financing at all anyway. It's about financing as a tool to help with the solutions that the clients need. And capacity, opening up of horizons and exchange of knowledge, bringing fresh air from other parts of the world where something has been done, not everybody reinventing the wheel, being catalytic, trying something new, giving the space to innovate, but allowing that to be scaled up. Actually, paradoxically to what we may be discussing, actually improving the monitoring and evaluation of how money is being spent compared to domestic financing, and overall focusing on strengthening health system will be the directions for the future. There was a very nice statement in the report that the development assistance for health was more effective in countries with better governance. But what is not more effective in countries with better governance? What about domestic financing? Is it more effective in countries with better governance? Yes. What is the corollary, right? So I think our effort should be on how do you improve systems and governance as part of what we do, and that still needs some of this collective thinking together. And I think we need to be also conscious of the confounding factors that something of this analysis brings. The world has become increasingly fragile. There have been many other waves of challenges that the world has seen. Health systems have become more complex. We are dealing with inflation, technology. So all of that is adding to the challenges of being able to measure, and then the disease burden completely changed in these 3 decades from a predominantly communicable MCH burden to an NCD burden. So our M&D systems also have to evolve and take shape. But I think this is a very good starting point at this juncture. And so long as we can keep a solutions focus and a knowledge focus in what we are doing, we'll be very ready for a future where we believe in country systems. We do much more results-based financing and not micromanage financing. Happy to micromanage where it is useful for the government and they want it, but not always. And of course, being strategic, catalytic, and focusing on capacity. Thank you.
Thank you. Great thoughts, great comments. Let's open it out. I have a couple of questions, but maybe later. Anybody? Priyadarshini? Sorry, did you raise your hands? Okay. Up.
Oh, very fantastic presentation.
You can say who you are.
I am Priyadarshini. I'm a research fellow here as part of Sandhya's team. Very fantastic presentation. And I just want to take on from the point that Somil and Girija mentioned regarding the impact of some of this funding. So this is just sort of me trying to make sense of what it does when it comes to the governance and policy priority to health and any of these other sectors. Is it possible to think of it in a way that what some of this assistance does is that it allows you to experiment with a whole variety of different things in pilot mode, etc., but it also ends up giving a somewhat of false sense of idea that things are happening, whereas the more difficult issues don't get resolved. So in a sense it is impactful. I mean, it is doing things, you're able to test, come up with things that can be done in a 3-year and a 5-year period, and it gives this sense that movement is happening and energizes the department, the sector in some way. But actually it becomes a lot more complicated and problematic because the more difficult things just don't get done, and you live under the sense that we are moving forward, but we are actually not. We are actually really focusing on very, very small things.
I will actually leave Somil to answer that question but from my point of view, it is that it is not, I think we gave a wrong sense that it is pilots. Actually, almost all the projects that I have worked in are large scale and throughout. What we meant and I think he echoed that you take a normal running system and you use this little bit of money that comes in the form of certain improvements in the system to push everyone towards results. That's how we design it. And it's not, the pilots may be early part of it. For instance, if you take our health systems project, it created better sub-district hospitals throughout Tamil Nadu. So most of, at least the larger funding agencies work in that. They don't work on time, but you are right in saying there may be small pilots of, as he's talked about, fragmented lending. We don't know what's happening elsewhere. But the large government, donor agency to government projects are mostly quite structurally placed. And we look at structural reform only.
And then Rahul.
I'm Anuradha. I'm also in CSEP, and I actually work in education. And I found this very fascinating because I've worked on development assistance in education and find many differences because education had donor harmonization. Their most successful program, the Sarva Shiksha Abhiyan, had World Bank and DFID and European Union together, and they had a very good system where every 6 months from both government, non-government and donors sectors, they work together to review. They made field visits and all. And the other interesting point was they somehow ensured that it's not fungible. Central government may have not done it, but central government used it to get a proportional investment from the state government. So if one sees the education budget, it rose very sharply in that SSA time. And now it's gone. Once that project is over, it's now flattened. The budget is flattened. And so the donor harmonization at that time was very important, around 2005 to 2015. But wasn't it in health? That's something I was just wondering.
Rahul, you had a question.
Brilliant. I mean, I really like the summary, especially. It's a closed door, so maybe the whole point of looking for waste, I think your framing makes us say it's not about waste, but inefficiency, this balancing that you talked about. Where's the money going? I think still we should be open to revisiting. On the point of 1%, have you been a small question? Have you been able to see where it's going in the sense, let's do a back of the envelope. I deal with technology policy. Back of the envelope is my friend. If it's 1 trillion and it's small, but vis-a-vis total healthcare, let's call it 20 trillion, some larger number. But if this is going to the poorest of the poor, then for them, even this is more than the bang for buck that you would think, because most of healthcare expenses are not these things, especially the communicable, as you said. It's on operations or other things at a global level, not for the poorer countries. So I think those granularity may be interesting. Carolina, for your slides, just to understand, in the cost benefit, or sorry, impact assessment that you showed, you compared, for example, infant mortality or whatever outcomes with or without a lag for the DAH spend. That was the analysis. Was there data to be able to say, here's the DAH on malaria, on TB, and look at the TB outcomes, the malaria outcomes? It wasn't clear if that level of resolution was done. And then the last macro question on the big policy, where are we spending the money, bang for buck? I looked at DALI's decades ago in a past life on technology and development. Back then, it was cardiovascular disease and smoking that were two of the very big killers. Do you see that level of depth of the non-communicable, and what's holding people back? Because I think sometimes governments don't want to get into that because fixing those means fixing supply chains, fixing awareness, fixing tax revenues for government. There's so many other things that are brushed under the rug. Thank you.
Okay, one more, and then maybe we're just going to move it to the panel. Siddharth?
So my name is Siddhartha Bhattacharya. I now work on the private sector side, and I used to work earlier in the development sector, and kind of have now. I closely look at private philanthropy, which is growing by leaps and bounds, at least in India. I don't know the rest of the world. And as you have the development sector assistance kind of tapering off, it has been saturated, or it has kind of slightly showing signs of coming down. Is there a common meeting point between a common agenda or common minimum programs between where the deficit in development sector lending assistance is going to be versus something that could be jointly addressed through either corporate social responsibilities or private philanthropy. Did you find any good practices, as you looked around the world in that? That's point number one. Point number two really is about, point number two is my last point. Point number two is, while you have about $800 billion to $1 trillion money that has gone into development sector assistance, has that resulted in commensurate investment from government or the other stakeholders? If that money is coming down, what is the interest of the counterparties to plow back the gains out of the development sector lending back into further technical support? Because if it has generated adequate capital at the end of it, then it is not going down in aggregate. It's probably even growing. Have you kind of looked at that number that way? Thank you.
So let me just.
You have a hard stop at 5:30. Yeah.
Yes. So, a question to on the analytics on the statistics we will come to do, but let me just comment a few points. Yes, there is no global board. Now, there is a reason why there is no global board. So if you have 30 years and $1 trillion, you would like to have some kind of board, even if it is not a commanding board, at least is a oversight board or is an accountability board. And I'm not an economist, but I'm very contaminated by them. When there is an equilibrium, there is a reason why it's an equilibrium. Because we didn't ask for it. So I think we have an issue. I think the issue is a fair point that most of our projects tend to be short, for years, correct? Which is an issue. However, that is exactly, I think, make our points. That's why you need to look at the whole portfolio. You need to have an aggregated evaluation, because if you do evaluations project by project, you do not capture exactly your concern. But if I look at the portfolio of the Global Fund or the World Bank or whomever, and I look at the portfolio of the last 15 years in El Salvador, hopefully is responding to strategy of cooperation, mutual, and it will have some logic. So yes, the pieces separated don't have a logic. Now, if at the end, the aggregate of the pieces don't have a logic, then we have a problem. So that is. And then we presented to OECD. So we have presented to a number of boards. So the whole OECD DAC, the whole WHO, the whole European Parliament, not USAID because it doesn't exist anymore, just really terrible. We were planning to do that. The harmonization and alignment, yes, there is a long, Paris Declaration, long effort. We have not really achieved it, not because we don't know how to do it, it's just we don't want to do it. It's just very difficult for donors. The 1%, yeah, so we look at the 1% allocation. So what is going? And unfortunately, data is scarce and the quality of the analysis is very scarce, but we do have that. So if you look at more granular, we can go through that. And why is that the governments don't want to do? I think governments want to do this shift. It's donors who do not want to do the shift. And there are, I think, 2-3 reasons. The one is lobby. So we are in La Vega, so, please don't quote me, but lobbies are different. So children don't have a lot of lobby. Others have more lobby. Second, and with this I find vaccines are lobbies. And I just want to, one anecdote, I represented the bank at the non-communicable disease summit in Moscow in 2014. And I made a pledge for shifting to NCDs. And I got one of the members of a big donor state saying we will never do that because HIV/AIDS or malaria have externalities, the other don't. And so we will, that's what we do. And it's a summary. And then finally, there's some crowd in, but not in low-income countries. So the evidence tends to show that there is a crowd out. of fiscal expenditures in low-income countries. In middle-income countries, it's the other way around. It has a very synergistic effect. Do you want to refer to the statistical and then your comment?
Somil has a hard stop by 5:30.
Oh, perfect. Yeah, and we also need to leave at 5:30. Otherwise, Amrita is going to kill me.
I'll try to very quick. I think the one thing, Girija ma'am already mentioned, is that the project design doesn't deal with the pilots in absentia, right? It says you do a detailed diagnostic of what are the pressing challenges, and they're very prioritized. And what is it that you should be doing that will have the maximum impact? So it's partly also some prioritization is from the government side and some prioritization from the development bank side, but there is a important prioritization. So you do not stop to focus on the bigger issues. In fact, you want to focus on the bigger issues, but there may be efforts that you do not want to launch something at scale without trying it out and improving it. So you may do a phased rollout, and that's how many programs would do it in 10 districts and then roll out to 100. But scale is part of how we are evaluated. Sustainability is part of how we are evaluated. So it's not something that you do just to show a pilot. You have to do something that can be scaled up, but you may want to be trying it. So pilots are part of a design to scale up within that 5-year horizon, for example. But the choice of issues is already because it is one of the bigger issues that has not been addressed. So that's kind of where they come from. And if it is not being done that way, then that's really not how the system is supposed to work. So I agree there may be aberrations, but this is not how at least a development banking system works. Private philanthropy is also equally fragmented. It may be big thanks to the 2% CSR allocations that we have, but you cannot really see how much of it goes into companies' own foundations, how much of it is coming together. So you do need platforms to share information. I remember with one industry chamber, Siddharth, we tried to create one such platform to crowdsource such information on who's willing to invest and from the government to get the priorities. But such things need to happen on a regular basis and get the platform. And is domestic investment coming down? Actually, no. There may be temporary things that you may see, but especially in an LMIC like India, if you put money, you see that the trend of public expenditure on health with growing income is actually much larger increase in the health expenditure than the income growth. So you spend a larger share of a larger pie as you grow richer. That's how the health systems work. Now, in the low-income country context, you may see something temporary, but then again, if you stay on system and you try to take enough precautions, you may be able to avoid it. And Cristian referred to that. But generally, as countries grow up the economic growth radar, you will find them putting more money of a larger pie in the health sector. Yeah.
Thank you.
Yeah, very short. There is one previous study that did that, like specific mortality for a specific disease. They found positive effects. We couldn't find robust evidence for redoing that with our data. I can discuss more with you or share with you the specifications. Thank you for the question.
This question has come up in different forms about value for money. And in the constrained supply, where will the big bang for the buck come from? I have to tell a small anecdote. I've only worked in India, and sometimes Cristian says you're a fish in the small pond and you should go see the world. But it's a big pond. It's a pond. And I used to think about all the work, and I was also in one of these agencies earlier. And I used to interact with multilaterals, bilaterals, everybody. That was my day job for years. And I used to look at all the work in that 1%. And there was so much hard work and sweat and toil by everybody. There were so many passionate people spending their lives and bloods, including all of us, in making things better. But we did a 4-year exercise with global experts on where India's health system was and what it should be. And it was shocking to me to understand how far away we were from where we needed to be. Despite all the hard work and the blood and the sweat and the toil and the best expertise from the multilaterals and the agencies in the world, we were shockingly poor in our health systems. And that's a published report by Niti Aayog, so everybody can go and see it. It was a 3.5-year effort by top experts from the world, assisted by Maulik and many others. So it was not only global people flying in, there were a lot of Indians involved. And that I took away, oh, there's something wrong with India. We have not figured this out. And then Cristian invited me to be a part of this effort. And I have become so sad with this effort to understand there's something wrong with the world system. It's not only India, many other countries have been suffering this broken system where agencies are, it's not that they're not trying to do their best. It's all incremental, it's all short term, right? And it's not honest conversations. People in hushed tones talk to each other about this is not really driving impact. They know it. We know in our hearts, we are doing small impact, but the reality of the big picture, we are not discussing with each other. So I think I've become so sad with this exercise. And at one point I asked Cristian, what did the leadership in the global health thinking, why did they not step up and have this honest conversation? And he was a leader in one of those large entities. And it's really shocking that the leadership at the global agencies level, whoever are the best thinkers, they did not have honest conversations, or people tried and their voices were not heard. And at the country level, we take tactical scale improvements and fungibility of funds or imbalance of power in the case of LICs, because 30% of their funds come from a single donor for HIV/AIDS. And there is no honest conversation. And so we need a disruption of the system. We don't need incremental change. I think this sharp decline in DH may actually be an opportunity to really rethink how we're working.
It is already in the public domain, and there is, yes. So we got a lot of feedback, and particularly with the OECD DAC, which is the house for all of the donors, by the way, which is in the middle of an earthquake of rethinking this. I also want to, I am old and I've been 30 years in this space. I am optimistic. I think one of the key issues is to put light on our challenges and failures. And the moment we do that, I do believe that there is space for innovations. Now, the innovations, unfortunately or fortunately, need to come from outside. We are not very prone to reform ourselves. So the objective of this report was, yes, we have a lot of issues, but there is a path forward, which is, solving these issues. It's going to be hard, but I after 30 years, I continue to believe in this. We need DAH, except that we need good DAH, not, any DAH for the sake of spending the money. So thank you for inviting us.
Thank you. Thank you all. Thank you for coming. Thank you for coming all the way and inviting.
Thank you very much. It is more just that, but I wanted to acknowledge Molly. Where is Molly? Molly, I'm acknowledging you. I just wanted to thank Molly. He did a piece on India that really shed light on the 1%. So what is that you actually do when you have very little money and you can actually activate change?
In fact, Girija gave some interesting examples of leveraging larger funds with that 1%.
I 400% of what we spend on health.
Yeah, exactly.
And it's not easy is the point. There's a much older than another non-cynic. I just think that it requires so much effort that we keep moving forward and then moving back.
I acknowledge you, so yes. Thank you very much. Thank you. Such a pleasure to be beautiful India. Work in India for last 10 years. Right? Strategy and lean technology.
That is the